through some of the thought processes I have when I deal with somebody with tremor that is a bit unusual and try to classify it. And then here and there will be some mention of neurosurgery, and there'll be hopefully time for questions at the end. So there's a couple things I'll blast through, which is how do we assess tremor, and this is one of the things we do. We have people draw these cursive letter E's across the page, mainly because if they're right-handed, they don't know how to write with their left hand very well. So that's the kind of thing we do, and that looks fairly smooth. It doesn't show a lot of tremor. And we switch this to his right hand. He immediately develops this shaky oscillation, which interferes with his ability to write. The rest of the exam is essentially normal. There was really nothing else on exam other than that brain abnormality, perhaps. I unfortunately don't have a video of the case 2, which was this leg-only tremor. It was a pretty dramatic tremor. It was fairly constant, but only during rest. And when he moved the leg, it would abate for a while and then reemerge. So I don't have that one, unfortunately. I have no disclosures, and I am going to talk about medications that are used off-label. So the first thing when we look at referrals for tremor is, what is it? As movement disorders, we try to classify things. Tremor is this oscillation of a body part, but as it turns out, there's always exceptions to the rules. So you have these irregular tremors, and a good example of that is cerebellar associated tremors, which characteristically have some pass pointing and things that throw in some irregularity. We still call those tremor. You also have regular non-tremor symptoms like myoclonus. There's a syndrome which I'll touch upon later called palatal myoclonus, where the palate rhythmically moves up and down. The EMG bursts are short enough to classify it as myoclonus, but it's rhythmic, and so some people do call it a palatal tremor. And then you get these irregular non-tremors. This is a case referred to me for tremor, and it turns out to be fasciculations, just of his pinky. And the diagnosis was a neuromuscular condition. It turns out that he has a cervical radiculopathy presenting with just tremor. Quick thing, this is just to illustrate the kind of things that we do when we look at tremor. Obviously, you try to provoke the tremor in some way. If someone has tremor when they play the harmonica, you're going to have them bring them the harmonica, have them play the harmonica. But the standard things we do is this lift the object to your lips, because it's functionally has two roles. One, it tells us something about the ability to function. And second, it puts the limb at a mechanical disadvantage, having the arm out like this holding an object, and so it tends to enhance tremor. So we routinely have people pour water back and forth. We tell them not to actually drink the stuff. And then on the right there, besides the writing and drawing the spiral that you saw, we have the postural tremor here. You also observe it at rest. You observe it during gait. And then she's going to do this wing beating posture, which is similar to this in just a moment, similar to the bringing the cup to the lips. So we're looking at the movement kinetic tremor now, finger to nose. You can see she has a bit of tremor during action. And then that's the standard posture that we look for tremor. So then once you observe tremor, where physicians tend to be smart people, and they always want to quantitate things. So there have been attempts throughout the last century in trying to quantify tremor. On the right, Dr. Peterson in New York devised this thing called a sphygmograph, where you have the bottom of that contraption placed against the limb. Pressure is transmitted to a membrane on the top, and the membrane is attached to a needle, which moves on a piece of smoked paper, which is moving along through a clockwork pendulum mechanism. And there are samples of his tracings that were presented at the American Neurologic Association, and the frequency of tremors that he got were comparable to what we get today. On the right here, I have some ways that we might want to sample tremor here in the clinic. The vibration is an iPhone app that I've used on and off for about a year and a half, and this one just came out, Tremor Tracer, which I actually haven't gone out and bought. But in general, these things are ancillary to the neurologic exam. You're going to depend a lot more on your exam, and these things can help track tremor over time. One thing we do a couple times a year is record tremor with EMG, and we also have an accelerometer that you can rig up and record accelerometry movement of the limb along with the EMG. And you know, again, it's an extension of the neurologic exam, so there's only really one major indication to go out and do this kind of study, and that's to look at orthostatic tremor, a particularly interesting type of tremor. And you'll see why in a moment. But it's another way that we'll sometimes document tremor or show people what their tremor looks like on the screen like that. So then the meat of what I want to talk about is how you classify tremor. When you read these texts on tremor, there's many different ways that they're classified. And this is a listing of things I'll talk about. There's classification by frequency. Frequency is probably the most salient thing you see when you see somebody with tremor or you record a tremor. And amplitude kind of goes along with that. And that's usually what you see as the first sentence describing tremor. It's this frequency, it's this amplitude, and so on. I favor the classification by phenomenology, which I have a table which I'll show you. And then there's what generates the tremor? What are the mechanisms of tremor? And that probably is most relevant to neurosurgeons because you're interested in when the oscillations are centrally located and whether you can do anything to abort the tremor. And then you can also classify by body parts. There's a few fairly interesting tremors that involve the tongue or involve the head or involve the leg. So let's go into these. So this is kind of a poorly reproduced table classifying tremor by frequency. There's a number of these attempts over the years. It's fine that the table's kind of obscure because I don't find it particularly useful. As you'll see, when you look at tremor frequency, and here is a list of tremors in some kind of random order. They're kind of random. And here is a distribution of what frequencies each one produces. And you can see they all overlap substantially, which is why they're not terribly helpful. The one exception is this guy here. This is orthostatic tremor. It has a particularly high frequency above 18 hertz. It's such a high frequency that you may not see it, and that's the only indication we use EMG for, is to detect that particular tremor. This side is a little more interesting. This is activation by, and that suggests in the presentations I've been given, that Colin gave, is what activates the tremor. And they have rest, posture, and goal-directed movements. And that really is what I would emphasize is the take-home message for the talk. This is the classification that I've come up with over the years and how to put the language together. And if there's anything to learn from this talk is this is how you want to communicate and describe your tremors. I've put in large cap letters the 4 major categories of terminology that are most helpful. And the first distinction is really between rest tremor, which is a tremor in a body part that is not activated with EMG and fully supported against gravity, versus an action tremor, which is tremor during any kind of voluntary EMG activity. You then divide action tremors into a postural tremor, which is when you hold the arm out, steady, versus a kinetic tremor when the limb or the body part is moving. Kinetic tremor is divided into simple kinetic tremor, which is just tremor like you saw in the lady who was doing the water pouring. She had tremor throughout her action, from finger to nose, posture holding, pouring water. So that's non-goal directed. It doesn't matter what the goal is. As long as the limb is in motion, it would classify as a simple kinetic tremor. This contrasts with intention tremor, which is another big category, which is tremor during goal-directed movement. In this case, the tremor increases during pursuit of a goal. And when you get closer to the goal, the tremor increases in amplitude, and this characteristically occurs with cerebellar-type lesions. And finally, there's a little subcategory down here called task-specific tremor, which is tremor that occurs specifically during task, which is what the primary writing tremor case illustrates, putting it into this kind of context. The significance of having these 4 terms, rest tremor, action tremor, intention, and task-specific, implies slightly different pathophysiology and localization. So the intention tremor I mentioned tends to be cerebellar in nature. The task-specific tremor, and there are exceptions to all these rules, tends to make you think of basal ganglia lesions and its context dependency. Things like dystonia in particular come to mind. The rest tremor is fairly specific for Parkinsonian syndromes, and the action tremor is the most nonspecific, but the prototypical disorder is essential tremor. And we'll get into those. Classification by mechanism. There's 3 listed here. There's a 4th one on top which I didn't put on, which is mechanical tremor. Mechanical tremor is tremor that we all have because we are all mechanical objects. We all have a resonant frequency in each body part. Those tremors, mechanical tremors, only come out, they're not clinically important because they usually are subclinical. What happens is if you get all amped up with lots of caffeine, or you're giving a talk in front of neurosurgeons, or whatever you're doing, or you're operating on a very, very close aneurysm, you can enhance your mechanical tremor, and it enhances at that characteristic frequency. So in the limbs, that tends to be around 8 to 12 hertz. In the proximal arms, it tends to be lower because the arm has a greater mass than just your hand, and that comes out around 4 to 6 hertz. What happens is that your spinal cord starts to reinforce the agonist-antagonist muscles at that characteristic frequency, and you start to vibrate. So we call that enhanced physiologic tremor. And you get that with all sorts of things, including drugs. Psychogenic tremor has a particular type of reflex-enhanced tremor where the person will stiffen, co-contract their limb, changing the inertial properties of the limb to a point to characteristically reinforce the resonant frequency of that limb. Central oscillators are the ones we talk most about, particularly with surgeries like thalamotomy and DBS and so on. Essential tremor is some kind of central oscillator. I'm going to show you a picture of the presumed oscillating circuit. Parkinson's tremor is an oscillator as well of central origin causing rest tremor. And then there's palatal tremor, which has its own kind of oscillator, and an orthostatic tremor with a unique brainstem level oscillator. Feed-forward loop disruption is probably the major mechanism of tremor related to cerebellar lesions. What happens is the nervous system operates efficiently with feed-forward control. So when we make rapid movements to catch a baseball or to do a goal-directed action, what happens is the motor plan that we execute is run through the cerebellum as a motor plan, and the cerebellum helps create a predicted sensory consequence of the movement. So if you're going to go, a great example is if you go tickle yourself and you try to tickle yourself, then your brain automatically predicts that you're going to feel the tickle when it comes. That matches what your prediction is when the sensory thing comes and you don't feel ticklish. That's why you can't tickle yourself. So what happens is if you lose the feed-forward mechanism, you don't have that sensory prediction anymore. This comes back later in the talk. And so you're dependent on feedback mechanisms. In other words, your brain's like, okay, look, I felt something, so therefore, did I make the correct movement? The feedback mechanism has a loop delay, and that induces, that's unstable and gives you the intention tremor of cerebellar disease. And so these tend to be cerebellar in nature and also can be the etiology of tremors of peripheral origin, particularly of demyelinating disease, where sensory information going to the nervous system is slowed, and therefore the loop delay is enhanced and you get bigger oscillations. Quick note about distinguishing central oscillators versus mechanical or reflex-enhanced oscillators. What we have here is on the top 2 traces, the top one is this is a frequency domain Fourier transform. So the peak indicates the peak power at a certain frequency. Frequency is on the x-axis. The top one is the accelerometer placed on the limb. The second trace is the EMG corresponding to that limb. And the top one is loaded and the lower one's unloaded, meaning you weight the limb with some weights. What happens is, in reflex-enhanced tremors, you get on the top a characteristic frequency in both the accelerometry, which means the movement of the limb, and the EMG, because the EMG is being reflex-enhanced. When you weight the limb, the frequency peak shifts down because you've changed the mass of the limb, and so now the characteristic resonant frequency has become lower. And so you can distinguish that. And so this implies a peripheral origin of the oscillator. On the other hand, if you do somebody with a central oscillator like essential tremor, you have a peak frequency on top in the unloaded condition. As soon as you load the limb, the tremor frequency peak stays the same. So it's unaffected by the mechanical properties of the limb and implies a central oscillator. And so in a fit yesterday, I was preparing the talk at Starbucks, and amped up on caffeine, I recorded my tremor over here. It's a 5-second recording on my iPhone app. And the Fourier transform gives you a peak frequency at around 10 hertz. And then I weighted my limb with a 2-pound weight. And this is what we get. First, the amplitude of the tremor diminishes, which is a really helpful maneuver in some kind of certain types of tremors of large amplitude. And you see that the peak at my characteristic frequency has gone down 10 hertz, but there's a new peak here that's lower, showing a separation out of mechanical tremor. So what does this mean? Any guesses? What's that? Right, so this indicates there's a physiologic component. This indicates that there's a central oscillator in my system as well. And so I do have an alcohol-responsive familial history of tremor in my family. So I've got both components of central tremor and peripheral tremor. The two main oscillators that we think about with tremor, the red one is the main one we talk about, the cerebellar thalamocortical loop. I'll move the pointer around. It's basically outflow from the cerebellum through the red nucleus to the ventral lateral and also the ventral intermediate nucleus of the thalamus, and then further on projecting back to the cortex, and this loops back downward as well. The basal ganglia probably have a role in it, but the main one that seems to oscillate is the thalamo-cerebellar type loop, with an influence from the cerebral cortex as well. The little gray boxes here indicate where lesions can lead to emergence of tremor. And so you can get tremor related to strokes in the thalamus or in cerebellar outflow. But interestingly not from a lesion of the cerebellum. Well, they actually have it here. I mean, you can get certain types of cerebellar tremors. For the most part, if you lesion your cerebellum, you don't get big-time tremors. And then there's this secondary oscillating loop, which is unique to palatal tremor, which is the inferior olive down here, going up through the inferior cerebellar peduncle to the cerebellum, through the dentate nucleus to the red nucleus and back down. That's the Guillen-Molleret triangle. And the importance of that one is, if you have this one set up as an oscillator, the standard thalamotomy procedures don't work. But for all the other tremors where you set up some oscillation in the cerebellar-thalamo loop, that's where the thalamotomy procedures tend to be helpful, or the DBS of the thalamus seem to help. Okay, so going into syndromes, so the big one is always, is it a rest or action tremor? And it's not, as we kind of showed in the cases, particularly the leg tremor, it's not always trivial to distinguish the two. But you can see this man on the right has a rest tremor, and this man on the left has a action tremor. See, as soon as he lifts his hands, they stop tremoring until it reemerges. So one thing about rest tremor is that, and is often confusing when you're trying to classify these tremors, is that rest tremor has this reemergent component. And what happens is, rest tremor, like the leg tremor guy, as soon as you move the leg or the limb, the tremor goes away. And after a latency of several seconds, the tremor reemerges. So rest tremor is not truly completely at rest. Rest tremor is what I call a motor idle tremor. It's like when your car engine is vibrating when you're waiting for the light to turn green, and as soon as you hit the accelerator, the tremor of the car goes away. And so when the person is holding the arms up straight, the motor goes into idle mode, and the tremor will reemerge after a latency. The other thing that I didn't have time to point out is when the man on the right starts to walk, the tremor is more prominent. So walking is a really, really good sign, because the motor system is so engaged in making sure that you have controlled falling, which is what walking is, and the arms tend to be in their idle state, and rest tremor is brought out very strongly. So So the rest tremor is the most specific of the tremors. It is specific for Parkinsonian states. Most of the time it's Parkinson's disease, but any of the neurodegenerative Parkinsonisms could cause it as well. Neuroleptic exposure can cause this kind of tremor, as well as any lesion in the dopaminergic nigral striatal system. And I'm not going to go over this because you had previous talks on Parkinson's disease. I just point out that this is the characteristic tremor you see. We talked about the gait and reemergent tremor, and the jaw tremor, the rabbit syndrome that we call it, when the lower jaw goes up and down, is considered a rest tremor and fairly characteristic also for a Parkinsonian state. So we can distinguish two types of Parkinson's disease. There's Parkinson's disease that characteristically starts with tremor, and that's what the man with the leg tremor was. It was such a characteristic rest tremor in him with a reemerging component, even in the absence of any other signs and symptoms. I mean, both cases had a subtle hint of rigidity. That wasn't very specific in my mind. But it's so specific that we thought that he likely had idiopathic Parkinson's disease. And, of course, a year or two later, that's what he turns out to have. Tremor-predominant Parkinson's disease tends to have a better prognosis and a slower disease progression. And it doesn't seem to correlate as tightly with these presumed biomarkers of dopaminergic deficit, like you get with this beta CIT SPECT scans and so on. The other type of Parkinson's disease is this postural instability gait disorder subtype, or akinetic rigidity subtype, which seems to correlate better with these markers for dopaminergic deficit. And so when you look at these clinical trials of Parkinson's disease, you're usually mixing these two up. And then post hoc, often they are distinguished from each other because of their differences in natural history. The tremor is treated, one reason you classify is that you try to get more specific treatment. So you treat these with dopaminergic medications. The rest tremor does respond, but the rest tremor doesn't cause disability in most cases until it's so severe it starts to overflow into action tremor. And then we involve people like neurosurgeons in trying to control disabling tremor. But in most cases, the rest tremor, and we did not treat that engineer guy with the leg tremor for a while. We just observed him and did our education thing about Parkinson's disease. It doesn't respond as reliably to treatment as rigidity and bradykinesia, to the dopaminergic medications. So the thing is we don't trace tremor. So we increase the medications to help treat the tremor, but because it's not disabling in and of itself, you usually do education and let that be to an extent. If it does get to a point where it's disabling, then that does respond to thalamotomy of the VIM nucleus, or DBS of VIM. But in most cases, because the person is going to be more disabled by Parkinsonian features, you go to the GPI and STN surgeries for Parkinson's disease, about which you had other talks. And there's a debate on, why is tremor-predominant Parkinson's disease better? Is it because this represents some kind of compensatory recruitment circuit that protects against the akinetic rigid syndrome, or is it a different neuropathologic subtype? And that's really not known. Okay, so essential tremor, you already saw this man, and Colin and I were talking about presenting essential tremor. But one thing about him, he has a head tremor, not a jaw tremor. So head tremor is characteristic in essential tremor. It happens in about 30 to 40% of patients with essential tremor. And voice tremor also occurs very frequently, which you can hear if he's not counting it. He was counting earlier. You could hear a voice tremor. There's usually this family history in the alcohol responsive tremor in 60 to 70%. So you diagnose this clinically with bilateral action tremor in the arms. I didn't write that down. It should be in the upper extremities, plus minus the head tremor for at least 5 years. I mean, that's the core diagnosis. But one of the features in the diagnosis is you have to have a normal neurologic exam otherwise. You are allowed, quote unquote, to have gait ataxia. So you're allowed to have some problems with tandem gait with classic essential tremor. Though, as I'll present, there is a debate now on whether essential tremor is more heterogeneous than we realize, and that it might be considered neurodegenerative in some cases. I went over the tremor features briefly. It is upper extremity, head, speech, voice, and then there's tongue and trunk. And there are cases of isolated head tremor and isolated tongue tremor, which some consider, in most cases, to be possible essential tremor. They eventually will evolve into essential tremor. We think of this as the most common movement disorder, but it's also incredibly difficult to get good data on exactly how common it is because the vast majority of people never come to clinical attention. They have a little bit of essential tremor, and it doesn't bother them. And so the trend in the last 10 years has been moving to population-based study, knocking door to door, having neurologists actually examine people on a statistical sampling method to try to ascertain the true prevalence. So this 2010 article was a meta-analysis of 19 of these studies in, I don't know how many studies, but across 19 countries worldwide. So it's a worldwide estimate, and after controlling for factors like countries where there's a lot of war, so the population tends to be much younger versus older type populations, there's some issues here. The prevalence gross is about 1% of the population overall, with over 65 years of age getting up to about 5%. So this is actually very prevalent, 1 out of every 20 people. There's a differential diagnosis for action tremors. So action tremors are nonspecific. They happen in many conditions. Enhanced physiologic tremor is the main one we can distinguish, and we can sometimes use that little weighting trick to figure out if there's a peripheral enhanced component to it. Most medications cause enhanced physiologic tremor, along with antipsychotics and antidepressants. And the other differential diagnosis, as I was sort of suggesting in the initial presentation, is that we get rest tremor confused with this, particularly with its reemerging component. We get peripheral tremor, post-traumatic tremor, intention tremors, dystonia, all these other types of tremors that we would now classify differently once you're done with the talk here. I'm going to mention 2 other things here. Wilson's disease you're probably all familiar with. Wilson's disease is a treatable disorder of copper metabolism. Characteristically is a mixed movement disorder with dystonia, gait disorder, gait ataxia, prominent ataxia, and a prominent proximal flapping large amplitude tremor. And so whenever you get somebody with a little odd picture, maybe some hint of liver disease or family history, you always check copper and ceruloplasmin, because it offers a more specific therapy for the tremor. This Fragile X ataxia premutation syndrome got some press about 5 years ago. Fragile X syndrome is this triplet repeat expansion disorder causing, and it's X-linked, and it causes mental retardation in affected male babies. There is a premutation where the triplet repeat is expanded but doesn't reach levels to cause the Fragile X syndrome. And there was a report that suggested that they can have essential tremor along with gait ataxia to an extent that's otherwise indistinguishable from essential tremor. Remember I said they were allowed to have some tandem gait problems. So in the more recent years, it turns out to be less important. I mean, it's still important from a research side to try to understand why these action tremors occur. But in surveys of essential tremor patients, none of these have been found, other than the group that first described it. So it probably has to do with a bias of the case control study of collecting these cases and having tremor. But as a population-based thing for essential tremor, it does not appear to be explaining a large percentage of our patients. Okay, in recent years, in spite of being the most common movement disorder, essential tremor has had surprisingly few neuropathology examinations. So this changed around 2003 when NIH started to fund a brain bank for essential tremor brains. And these were analyzed and led by Alon Lewis at Columbia, and being analyzed with modern neuropathological methods with case control brains, very well-established clinical histories of long-standing essential tremor without other comorbidities that they knew of, and quantitative counts in areas like the cerebellum. And it turns out that the cerebellum, which has been implicated in sort of softer scientific studies, where you have dropouts of pyramidal neurons over here. I'll use my pointer. You see pyramidal neurons in the, Purkinje cells in the cerebellum here with a patchy dropout on this side. And the Purkinje cells on this H&E stain show these ballooning torpedoes. These are axonal swellings that are leading to Purkinje cells. So these things have been found in 30 to 75% of cases of essential tremor. It varies because there are 2 or 3 different series going on looking at these things, but this appears to be present in a fair percentage of people. Thanks. There's also this less clear neuropathology described as Lewy bodies found in various brainstem nuclei. Lewy bodies are the alpha-synuclein inclusions you see in the substantia nigra for Parkinson's disease, and they're also found in the things like progressive supranuclear palsy and Lewy body dementia in the cortex. So the significance of these is less clear because there's an idea that if you see Lewy bodies in the brainstem, perhaps these are just related to preclinical Parkinson's disease or something else. So that's not yet resolved. But, you know, there are a few other hints clinically that essential tremor could be neurodegenerative, including the fact that the incidence increases with age, the symptoms characteristically worsen with age. We get essential tremor patients evolving into Parkinson's disease with a much greater than expected incidence, and that's been observed both clinically and in this more recent report. And then if you do quantitative analysis, you actually have features of intention tremor and past pointing in up to 25 to 30% of essential tremor patients, implying cerebellar pathology. On the other hand, 60–70% of people are responsive to alcohol, which characteristically worsens cerebellar symptoms. So there is still a debate on whether the actual symptoms you get with essential tremor, the tremor itself, is due to the pathology or if it's due to a consequence of oscillation in the cerebellum and thalamus. Treatment, we don't tell people to drink alcohol, but we don't discourage them from having wine at dinner if it's disabling them for meals. The mainstays of therapy are propranolol and primidone, a beta blocker and an anticonvulsant. These are the only 2 with level A evidence on this American Academy of Neurology review of treatments for essential tremor, meaning multiple multi-center randomized controlled trials. Primidone tends to be better tolerated over the long run, but you have to take it every day on a continuing basis, while propranolol you can start as needed, and it's also what we use for performance anxiety or performance anxiety associated tremor. After those 2 drugs, because of the prevalence of essential tremor, all sorts of other medications are tried, and none of which have really panned out in randomized controlled trials. And I've listed them here, and we usually try things like gabapentin, topiramate, and I actually try clonazepam after those 2. You know, from the preceding discussion, you can see that essential tremor could be much more heterogeneous than we think, and that might explain some of the difficulties we're having in identifying specific treatments for it. There have been a few studies of botulinum toxin for essential tremor that's disabling in the limbs. It works actually really well for head tremor, but the risks of weakness tend to outweigh the really mild benefits you might get for limbs. For neurosurgical options, medication refractory tremor, the usual target is the thalamic VIM nucleus. And when you put an electrode into the VIM, you can actually find tremor synchronous cells. So the cell firing will be in sync with the visible tremor. And this tends to be fairly predictive of how well the tremor is going to work. And in fact, in essential tremor, it works so well, you often have this micro-lesion effect, where you can just leave a DBS electrode there, and for weeks to months afterward, you don't even have to turn it on. You have a resolution of the tremor contralateral to the thalamus. Thalamotomy was used before DBS was developed with up to 80 to 90% response rate. This is a response rate, not amount of tremor response, with varying amount of adverse events reported, things like paresthesia, weakness, all the way to, I think there was 1 death in like the cases that were reviewed in this summary of treatments. DBS was developed and tends to have fewer adverse events than thalamotomy. And it must be said that, you know, none of these have been in any kind of controlled trials, right? Now, at least DBS, you can do a controlled trial in that after the DBS electrode is in, you can turn it on and off in blinded fashion and actually demonstrate improvement in tremor. 60 to 90% improvement, a few adverse events. You can do bilateral DBS, which is helpful for bilateral tremor, which you cannot do with thalamotomy because that causes a lot of dysarthria and dysphagia. And there is still, it is unclear how well DBS bilaterally or unilateral really helps voice or head tremor, these midline type tremors, though it's being looked at. Okay, quickly on a few other tremors. Now, on the third type of big category, the intention tremors. These are related to the cerebellar tremor, and I already told you about the feed-forward mechanism. And this is clearly implicating the cerebellar thalamic loop, prominently lesions in the outflow in either the white matter coming out of the cerebellum, explaining why you get a lot of this with multiple sclerosis, and in the red nucleus and pathways up to the thalamus. And you can get this with any sorts of lesions, and usually when you have intention tremor, you can find neurologic signs and symptoms of brainstem lesions, multiple sclerosis, or other issues. And it tends to be a low-frequency, irregular, goal-directed tremor. Went over that already. There's a tremor that used to be called rubral tremor. Used to be called, before that, kinetic tremor or rubral kinetic tremor. So that's why we're so obsessed with terminology, because it gets very confusing. So in 1991, this tremor conference trying to unify a classification called it the Holmes tremor, after Gordon Holmes, who first described it in World War I soldiers getting injured in the cerebellum. It's a combination, it's a dramatic tremor with a rest tremor that can involve the whole body. So you have people just laying down in bed and they have a rest tremor, including the trunk. And then they have an action and intention tremor as well. So they think about moving, the tremor increases. They start moving, it gets even worse. When they start to actually reach for an object, forget about it. It gets very bad. This evolves over weeks to months after injury, and it's very characteristic for midbrain lesions around the red nucleus. But it's not specific to that, which is why they got rid of the rubral term. And you often get the neurologic localizing signs with it. And it's, in my mind, it's basically related to the cerebellar intention tremor. These intention tremors don't respond very well to medications at all. And if it gets disabling, then then DBS is probably your major resort. Occasionally, I've had success in sending people occupational therapy for weighting of the limbs to try to suppress the proximal component of the tremor, which is sometimes helpful. What surgery doesn't help with is the ataxia. And so you have to assess these people and make sure that tremor is the major disability and not the ataxia. Otherwise, it's interesting that VIM remains the usual target. And VIM seems to be pretty nonspecific. It looks like to be a final common pathway oscillation for all these tremors, including the rest tremor of Parkinson's disease, the action tremor of essential tremor, and the intention tremor from cerebellar outflow. There have been fewer studies of DBS and intention tremor than there are for essential tremor. And the responses are considered less predictable than for Parkinson's disease or essential tremor. Now I'm going to mention something about palatal myoclonus or palatal tremor. And most of what we know is from these cases of what's called symptomatic palatal tremor. And this implicates the olivary rubral dentato loop down here. And what happens is denervation of the inferior olive tends to, through these two lesions, usually the central tegmental tract here, tend to denervate the inferior olive. And the olive develops a compensatory hypertrophy weeks to months later, and the olive has a high incidence of gap junctions and allows them to develop these oscillations. And so they develop spontaneous oscillations at 1 to 3 hertz, and they trigger movements of the soft palate, which can be pretty annoying. The levator villi palatini muscle tends to be the one involved, and the ENTs can usually do Botox in there, which is probably the treatment of choice if it's very bothersome. Unlike other tremors, these tremors tend to persist during sleep. So in fact, they're probably best classified as a form of rest tremor, though not specific for Parkinson's disease. Because they involve this loop, they don't respond to thalamic DBS. And then, of course, you always have these essential palatal tremors, which is its isolated symptom. These guys, because they are tied to lesions, usually have a lot of associated signs, eye movements, and ataxia, those sort of things. These guys have this as an isolated symptom of ear clicks or palatal movement, and there's no lesion that can be found. And some of these are even considered to be a variant of tics. That people, and they don't always persist in sleep as much as the other type do. We're going to finish up with task-specific tremors. There's three I'm going to talk about. There's the dystonias, there's primary writing tremor, and orthostatic tremor. So dystonia is this contraction of muscles that's involuntary, but it tends to pull the body parts into certain postures. And so this is somebody who has head tremor. And I don't remember, actually, whether she was confused with essential tremor or not, but that's a pretty frequent question being asked. Is it essential tremor or dystonic tremor? The three things two things that really help is a null point, meaning if she turns her head to the right, the tremor is less than when she turns her head to the left. There's a characteristic posture that is preferred. You don't see that with essential tremor. It kind of tremors no matter what way you look. And she's demonstrating a sensory trick where you just touch your face and the tremor improves. And that's characteristic for dystonia. That does not occur in essential tremor, where the central oscillator just goes no matter what. And we can talk about that, but Botox works remarkably well for these people. And because it's similarity to head tremor in essential tremor we do the same thing, and they seem to tolerate it very well and do quite well. So this is another person with writing tremor, but what you notice about her is she has a flexion of her wrist during the movement, which is impairing her ability to write. She also has dystonia of the fingers that are pulling the index finger down, causing the pen to fold into her fist. So because of observations like this, most people consider primary writing tremor to be a variant of dystonic tremor of the limb, a task-specific dystonia, which is, and so I'm illustrating this to sort of show the parallel between the first case and what we think is dystonia. In dystonia, the treatments shift, right? You have a certain medication that we use for dystonia, namely artane, clonazepam, and sometimes baclofen. It's kind of a more specific cocktail we use for dystonia, which you don't usually go to for essential tremor, or if you classify primary writing tremor as a variant of essential tremor. So I feel that they respond much better to the dystonia treatments. The other thing is Botox can help certain types of dystonia of the limb, but for primary writing tremor, because there's no characteristic posturing that occurs, you have a lot more side effects and tends not to be used as much. Last tremor. Oh no, I have two more tremors. So we're in the task-specific tremor. Orthostatic tremor is a very specific tremor that occurs only when the person stands up. And it occurs at a very high frequency. Here it says 13 to 18 hertz. It's usually above 16 hertz. And what makes it really remarkable is that it is bilaterally synchronous. All the other tremors I've talked about are asynchronous. They have independent oscillators on the two sides of the body. This one, the two tremors are side-to-side reinforced. So you can imagine if you have tremor that's bad of essential tremor or intention tremor, you can actually hold the two limbs together and suppress it to a degree because they phase cancel, and people often do that. In this, if you were to grab the two hands, then they reinforce because they're synchronous, you get much worse. And because it occurs when they stand up, they usually complain not of tremor, they complain of unsteadiness with walking, and you get very, very bizarre gaits with these people. And this is where we use the EMG recording. And if you're lucky, you put EMG electrodes on the legs, and you always put them on the two sides. You get this really rapid onset of fast EMG bursts on both legs. And what's really interesting is you can record this throughout the body. So you can record this in the arms, the paraspinal muscles, the sternocleidomastoid muscles, and they all are phase synchronized. So these are coherence maps, mapping the frequency coherence between two muscles. And here they're measuring gastrocnemius to the tongue muscle with a peak. And here is paravertebral muscle and the tongue, sternocleidomastoid in the paraspinal muscle, and gastroc and sternocleidomastoid. They're all synchronous. So it implies a very strong midline oscillator, probably one that's responsible for balance and walking. Treatment tends to respond best to clonazepam, but it doesn't respond to a lot of things. And just, I think, a year or two, there were the first 2 cases of DBS of VIM done for orthostatic tremor. They're just case reports reporting success. But there's not a lot of cases of this. And the last tremor is psychogenic tremor. There's kind of two kinds of psychogenic tremor because, well, there's two types. One is this coherent rhythmic tremor, which occurs at a low frequency, usually around 6 hertz, at most 8 hertz. And this is probably semi-voluntary movements where the person actually has some kind of entrainment. You see this in this guy's arm. This is the type that entrains. You know, when you have them do other actions with the other hand, then the voluntary rhythmic movements tend to entrain. The co-contraction is what I talked about, where you stiffen the arm, you cause it to vibrate at a characteristic frequency. That does not entrain. So entrainment, when you're trying to distract the person, doesn't work, and it's not pathognomonic for psychogenic tremor. But the co-contraction ones do show distractibility. So if you have them move the limb in various ways, then the inertial properties of the limb disappear, and the tremor will go away transiently. And you can read all about these standard clinical things we talk about. This one's often interesting. When you load the limb, as you saw in the tremor recording that I did, the amplitude goes down. In fact, we use it as a treatment. And in these cases, the amplitude tends to increase. They tend to exaggerate their tremor response. Of course, he's displaying a lot more than tremor. He's got all sorts of different movements. And the variability also helps make the diagnosis. We see about 10 to 15% of our patients have psychogenic movement disorders of some type. And there have been some recent work on this, which I thought I'd bring to your attention. This is a work done at NIH at Mark Hallett's lab, and they were recruiting psychogenic tremor patients for 5 years. And these are a difficult group to recruit. They had 8 patients. These were people with a characteristic tremor that could be that was clinically diagnosed as psychogenic tremor or a form of conversion disorder, and they could induce it. They could put their arm in a certain posture and the tremor would start, and then they could stop it. So they could go into an MRI scanner and say, okay, induce your tremor, and off the conversion tremor would go. And then at the same time, they had blocks of rest, and they had blocks of imitate your tremor. So just do your tremor, imitate it in voluntary action. And using videotape recordings, they could show that the voluntary imitation of their tremor was comparable to the psychogenic tremor they displayed. Okay? And so this was a within-subject study of 8 patients with psychogenic tremor. 7 of them had right-side tremor, 1 had left-side tremor, and this is what the comparison showed. The top one is a conjunction analysis of both the voluntary and the psychogenic tremor minus rest. And you get this predicted oscillation that we've been talking about in the motor cortex and the cerebellum. Then when you compare the voluntary minus psychogenic, you get a hypoactivation in the right temporal parietal junction, meaning under circumstances of producing a psychogenic tremor, they have an underactivity in this part of the brain that does comparisons of the internal predictions with actual events. So this is the cortical correlate of what the cerebellum does in predicting sensory consequences of movement. What this suggests as a hypothesis is that perhaps what's happening is psychogenic tremor, they do not compute properly the consequences of their action. Therefore, they don't perceive them as being self-generated, and therefore it is being done to them. So anyway, it's an interesting hypothesis, but I think this kind of work is really interesting. And we, like I said, we see more than a few of these, and they're interesting. They're also exhausting, but they're interesting. So, so that's talk. I'm sorry I didn't have more neurosurgery to talk about, but I wanted to take you through the kind of things that we deal with when we think about tremor. And this table is really something I put together over the years to help convey the thoughts I had on tremor. It's not just that the classification is important for guiding treatment, because, look, the pathophysiology is incompletely understood. We do the same sort of medicines for a lot of these things. But it's also important for doing research going forward and trying to classify the tremors and figuring out what is happening, which is why the essential tremor work right now with the neuropathology is really interesting, trying to subdivide that into groups that we can actually do something about. From the neurosurgery side, understanding the central oscillators is important because, you know, we can refer people for neurosurgery for disabling tremor, and for the most part, you'll get, with the exception of Parkinson's disease, a thalamotomy or a DBS of the VIM. But there are a few groups that are started to explore other areas in the subthalamic nucleus, the white matter fields behind the subthalamic nucleus, the white matter pathways to VIM, trying to refine the surgical